So with this disorder, we have a part of the lung that has collapsed, which means there is no air in it. And when that occurs, then we are going to not have gas exchange that's going on because, again, no air is there. And that is going to lead to low oxygen levels. Okay. So what's occurring with this one is that the alveoli become airless for some reason. Okay. Kind of have to discuss kind of some primary reasons why this is going on. But for whatever reason, it becomes airless. And what is going to happen is the natural elasticity of the alveoli tissue is going to actually force it to close shut. Okay. So just like a balloon in its natural state, it is more shriveled up. It's not naturally blown up and stays that way. So when the air leaves it, it's going to collapse in on itself. And so our lung tissue is the exact same way. Okay, so if we do not have that portion of the lung open, then we are obviously not having gas exchange happening, and blood flow is also going to be impaired going through the lungs. So this is both a problem with ventilation and with perfusion, or the gas exchange that's going on within the lungs. Okay, so if we only have a small chunk that has collapsed, that is not something that is going to kill us, but if we do not get that reinflated, that tissue can become necrotic and infected and can cause more damage. So we want to get it fixed as quickly as possible. Okay, there's a couple of different kinds of atelectasis that we have. The first one is compression atelectasis. So this is happening when we have pressure that is pushing on our lung that is going to force it to close. So we'll look at some different reasons for that. So things like a tumor. Okay, tumor is starting to take up more space, and it's going to push on the lung, and it will cause a portion of the lung tissue to collapse. Okay. When we have pressure differences within the pleural cavity of the lung, due to air getting inside of it or fluid, we will talk about this when we look at pneumothoraxes, but that can also cause our lung to collapse as well. Okay, and then there's another type of atelectasis called a postoperative atelectasis. So this is going to be occurring after somebody has surgery, about a day or two afterwards, and this usually has to do with somebody who's had abdominal surgery. Okay, so people who are in pain are not going to be taking nice deep breaths. Okay, so we want to get them enough out of pain that they can breathe adequately so that their risk for atelectasis drops. But again, we don't want to overly medicate them for pain, because that can actually slow and or stop their respirations, because that is going to affect the breathing centers within their brain. Okay, so there's this nice little sweet spot where we give them enough pain medication so that they'll breathe nice, good deep breaths, but not too much that they're going to actually stop breathing. Okay. And then if they are in pain, they're not going to be wanting to do a lot of coughing. So we're going to have to medicate them for the pain and encourage them to cough as much as possible, even though we know it's going to hurt. Okay. So signs and symptoms of this, again, if it's smaller areas, they're going to be asymptomatic, but for larger areas, they're going to have lots of trouble breathing, and their respiration rates are going to pick up, and so is their pulse. They can have some chest pain with it, especially if it's one or more of our compression atelectasis. Okay, for that area, they're going to have absent breath sounds. So you can Google images of chest x-rays that are done of somebody who has an atelectasis. So you will see that the huge big area where the lung should be inflated, and then maybe the affected lung that has collapsed is taking up a significantly smaller portion. If it's a full lung that has collapsed, you're talking about less than half of the the spot where the lung should be is actually lung tissue now. Okay, so in those areas where the lung is no more because it's deflated, they're not going to be having any breath sounds when we auscultate over that area. Okay, so again, using our stethoscope to auscultate that and finding out that they don't have breath sounds there. Okay, so our next thing that we're going to talk about is pneumothorax. So we'll figure out why we have a bloody knife up here in just a second. Okay, so this is air within the pleural cavity. And we said that the pleural cavity was, you have the lung itself, and then you have the sac that it's located in. Okay, so we talked about the pleural versus visceral membranes within the pleural cavity. So this is air within that sac that is actually going to crush our lung. Okay, so we get too much air in there, then that is going to cause our lung to collapse. So this can be a cause of atelectasis, would be pneumothorax. Okay, so let's look at a couple of different types of pneumothoraxes. So the first one we have is a closed pneumothorax. This means that nothing was introduced. It's going to make more sense when we see an open pneumothorax. But basically, something is occurring with the lung itself that is going to cause this problem. Okay, so let's say we have a tear in the lung tissue itself, and that is going to allow air from where it should be located, which is inside of the lungs, is going to let it escape into the pleural cavity or the pleural sac. Okay. So if we jump all the way back to emphysema for just a second. So we had the troubles with the blebs, or the alveolar tissue that was not functioning very well. It became very weak, and that they could rupture. Okay. So that is now a hole in the lung, and that air is going to escape out of the lung and go into the pleural cavity. When we have enough air that's going to build up in there, that air is actually going to crush the lung from the outside, causing the lung to collapse. So that is a closed pneumothorax. So let's look at an open pneumothorax. Oh, sorry. We have spontaneous in between. So sorry. Okay. So with a spontaneous pneumothorax, there can be a tear within the lung tissue itself that causes the lung to collapse. The scary thing about spontaneous pneumothorax is it can basically happen to just about anybody. Okay, that's why they call it spontaneous. Not really anything, for the most part, causing it. There's no way to know if you are at risk for this, but yeah, it can just happen. So that's exciting. Keeps you living, keeps you on your toes. Okay, so let's look at an open pneumothorax. Okay, so with this individual, we actually have a puncture in the chest wall cavity. So say with this giant kitchen knife up here, puncture in the chest wall cavity that is going to introduce atmospheric air into the chest, and the pressure difference is going to make the lung collapse. Okay, so going back to the basics of the respiratory system, atmospheric pressure is a lot higher than what it is inside of our chest, inside the thoracic cavity. Okay, so when we have an opening between atmospheric air versus the pressures that are located kind of in the atmosphere around us versus what is the pressures inside of our chest cavity, the chest cavity is a lot less. And so when the atmospheric air is exposed to that, it is going to crush the contents within. Okay, again, the pressure on the outside is higher than the pressure on the inside, and so when we have that opening in between, it will crush the lung, causing it to collapse. Okay, and then we have what's called a sucking wound, which is a really, really large opening in the chest wall. So maybe not just like a little puncture wound, say like with like a little ice pick, we're talking about a major wound. Okay. Every time this individual is going to breathe in and out, you're going to actually hear that noise coming from the wound in the chest wall. So it's like having a second nose located in your chest. Really weird, okay? But it is going to cause all kinds of problems within the chest cavity, and we will see those in just a second. Okay. So the more air you have going into the chest cavity that's not inside the lungs is going to affect our respiratory and cardiovascular system more. Okay. So the less amount of air that's going in there, the less effects that we have. Larger amounts of air, the greater effects. Okay, so let's talk about the worst kind of pneumothorax. We're going to talk about a tension pneumothorax. Again, horrible for the individual, but very interesting to learn about. Okay, so this is the most serious form. It can happen with either the open or the closed one. As far as we actually have a open wound from the outside of the chest cavity, or we don't, or say like the lung ruptured, okay, and we can get air in that way. So either way, we can have a tension pneumothorax. So what is happening is we create a one-way valve. So instead of the sucking wound where we can hear air go in and go back out, with this one, air is only going to go in and then it's going to get trapped there. Okay, so every time the individual breathes in, air is going to be pulled into the chest cavity. When they breathe out, the valve is going to close and it is going to trap the air in there. Okay, so they take a breath in, a little bit of air leaks into the pleural cavity and is trapped in there while they breathe out. When they breathe in again, we're going to trap a little bit more air. And so with each breath in, they're going to trap more and more air within the chest cavity. And each time they breathe out, nothing is going to happen. Okay. So again, we're going to increase the amount of air within the pleural cavity with every single breath. Okay. So eventually what is going to happen? So we already have a collapsed lung on the affected side. So say they had a knife wound in the left part of their chest. So their left lung has collapsed. When we keep increasing the amount of air that's in the chest cavity is open. So you have a lung, you have your heart in there, you have your esophagus, you have your bronchial tube, you have your vena cava is located in there, heart's located in there, you've got your other lung. They're all in one room, if you can imagine it. Okay, so when we start increasing the pressure of one side of this room, we're going to start pushing the contents of the rest of the room off to the side to make way for more air that is coming into the chest cavity. Okay, so you are going to start squishing the heart over, you're squishing the collapsed lung over, you're going to start pressing on the good lung, you are going to start kinking off the vena cava. You're going to end up with all kinds of major problems just because of this pressure difference. It's going to push everything out of the way. Okay, when this happens and we have all of this, the contents of our thoracic cavity is going to move. We're going to call it a mediastinal shift. So this is a huge big deal, real scary. Okay. With the pneumothorax or with any type of pneumothorax, we're going to have severe hypoxia, okay, and respiratory distress can develop, which can lead to failure, and further than that, to death. Okay. All right. So let's talk about a flail chest real quick. Flail chests are also very interesting, I think. Okay. So falls and car accidents can cause a lot of our chest wall injuries. With a flail chest, usually you have multiple broken ribs in a area. Okay, so if we have 3 to 6 ribs in 2 different places that break, and or we have the sternum that actually breaks away from the ribs, okay, we can have a flail chest. So say we have these 3 ribs here, so they broke, say the sternum was over here, so it broke off the sternum, but then it broke off the other section of ribs as well. Then that is going to leave this chunk to be kind of free floating, if that makes sense. Okay, so the rigidity of the chest wall has been lost, and what is going to cause, or what this is going to cause, is called a paradoxal movement when we breathe in and out. So when you breathe in, take a breath in, your chest wall goes out, and when you breathe out, your chest wall gets smaller to force all that air out, and your chest wall goes in. With flail chest, their chest is going to, their movements are going to be opposite. So when they breathe in, instead of their chest wall getting bigger, their chest wall is going to get smaller. And when they breathe out, instead of their chest wall getting smaller, it's going to get bigger. Okay? So complete opposite movement of what is normal. Okay, so during inspiration, the broken section is going to move inward versus outward. So that is going to keep that lung from being able to expand fully. And then during expiration, instead of it helping to push all the air out of our lungs, it is going to move out. Okay, so these changes in pressure can also cause a lot of major problems, like we did with our tension pneumothorax, and that can also affect how the vena cava is returning blood back to the heart. If we have decreased venous return, we will also have decreased cardiac output, which is going to cause all kinds of problems. So flail chest is definitely an emergency as well. Okay. So I want you to compare the cause and effects of a closed pneumothorax, a tension pneumothorax, and a flail chest, and how that will affect ventilation and their cardiovascular activity. Okay, so let's look at the first part where it says cause and effects. So think about your causes of a closed pneumothorax, think about your causes of a tension pneumothorax, and think about your causes for flail chest. Okay, and then how is that going to affect how they're able to ventilate or breathe? Okay, how is the closed pneumothorax going to change how they breathe? How does the tension pneumothorax change how they breathe? And how does the flail chest change how they breathe? And then along with that, how do these things also cause cardiovascular problems as well? Okay, so with a closed pneumothorax, again, this was not an open wound to the outside. So this was something going on with the lung itself. So say we had a rupture of the lung. So the cause of a pneumothorax is going to be usually like a weakening of the wall of the lung. Okay, so that can be a cause, which is not what's causing our tension pneumothorax. Tension pneumothorax can be a closed one, but it could also be open, which means that we actually have an opening in the chest wall to the outside world that can cause a tension pneumothorax as well. And then flail chest is usually from some sort of chest wall injury where we have broken ribs that are occurring. Okay. So with ventilation, with a closed pneumothorax, we have that lung that has collapsed because of all the pressure. Every time the person breathes in, we're going to put more air into the pleural cavity. When we breathe out, some of that air will escape back into the lungs, some of it won't, just kind of depends. If it's a tension pneumothorax, it will get trapped within the pleural cavity, and it's not going to be able to escape anywhere. With flail chest, we have that paradoxical movement of that section of ribs, and that is going to impede how well we can ventilate as well. Now the closed pneumothorax, we can put some, we're not going to be aerating the blood like we should, getting the oxygen into the cardiovascular system like we should. With tension pneumothorax, we can actually, along with Flail, we can actually be pushing on the vena cava, which is going to decrease venous return and therefore cardiac output. Okay. All right. So our next to last thing that we're going to talk about is distress syndrome. So this is acute respiratory distress syndrome, sometimes called adult respiratory distress syndrome, but ultimately called ARDS. Okay. Most of the time this is happening because of some other condition that's going on. Large times it's sepsis, or we have a some sort of bacterial infection within the blood. Shock can cause this, burns, aspiration, smoke inhalation, any of those things. Okay. Usually this has happened 1 to 2 days after whatever was the original thing. So maybe 1 to 2 days after somebody's suffered from a major burn or has escaped, say, a building that has been on fire or has been majorly sick with sepsis. Okay. So usually this is happening because multiple organ systems are kind of failing at this point anyways, and respiratory is going to be another one. Okay. So the most part that the injury is coming from the alveolar wall and or the capillary membranes. Okay, so something is occurring in that area which is going to cause this to happen. Okay. So if we have damaged the alveolar wall or the capillary membrane, we're not going to be diffusing oxygen as well. Okay, blood flow is going to be reduced. We have difficulty expanding the lungs, and then we can also have collapse of the lung here and there. So signs and symptoms of this is that they're going to have lots of difficulty breathing. Okay, they're going to be very restless. Their breathing is going to be very shallow and very rapid. Their heart rate is going to be very increased. Oxygen levels within the blood are going to be down, and they're going to be using accessory muscles in order to help them breathe. Okay, so when you're naturally breathing, your diaphragm is doing most of the work. Okay, we're talking about the use of accessory muscles. We're talking about using your abs. We're talking about using your intercostal muscles a lot more in order to help you either take in air or to expire air. Okay, so when you see them really working on trying to breathe in or to breathe out, we know that they are in distress and we need to help them as best as possible. Okay, they may have rales at this point or crackles. Could be fluid inside of their lungs, kind of depends on what was the cause of this in the beginning, and they could be blue because of their low oxygen levels. So treatment for this, again, we have to treat the underlying cause. So if it was sepsis, we need to treat that. If it was shock or burns, then we need to treat that, and that will hopefully correct our distress. Oxygen therapy is going to be a huge thing for them. So definitely giving them the oxygen that they need. We can put them on mechanical ventilation. So whether that is like a BiPAP or CPAP, or we can actually put them on a ventilator so that the ventilator does all the work for them and allows their muscles to rest. Okay. Using those accessory muscles are going to tire out our individual a lot. Okay. So if we can take the workload off of them as best as possible, that's going to help them out. Okay. The prognosis is not very good. Okay. 30 to 40% of our patients that go into respiratory distress syndrome are not going to be making it out. okay? If it's caused by sepsis, then 80 to 90% of our patients are not going to be making it, okay? So our last one is respiratory failure, okay? So distress meaning that we are having difficulty, and if you do not help us, we're going to go into failure, okay? So at this point, failure is a huge thing that we've got to kind of rescue our patients out of. Okay, so this is also called ARF. So again, multiple different disorders can be causing this. So this is indicated when our oxygen levels are below 50, under the pressure of 50, okay? So if you look back at your normal lab values, we shouldn't be anywhere between 80 and 100. So 50 has been greatly reduced. And then with our PaCO2, so our partial pressure of carbon dioxide is greater than 50. It should be between 35 and 45. Okay, so we've increased. We have a decrease in oxygen, and then we also have a decrease in our serum pH, meaning that our pH of our blood has dropped from the normal 7.35 and 45 to below that. Okay. Okay, so oxygen is always a major concern because the lungs are the only ones that can provide us with oxygen. So if our lungs are not functioning correctly, then obviously we are up a creek without a paddle. Okay. So because the central nervous system also kind of controls how well we are breathing, we are not getting oxygen, then the central nervous system is also going to be affected as well. Okay. If we do not get them out of the respiratory distress, they will go into failure, and failure is basically circling the drain. Okay. And we want to help them as best as we can, because if we leave them in respiratory failure, they will eventually go into respiratory arrest, which is their lungs and their diaphragm and everything has just been overworked, and it gets tired and it just says, I quit, and it stops. Okay. When this stops, the heart is quickly going to follow right behind it and also going to arrest. Okay, so again, many different disorders can cause respiratory failure, but since we've already kind of discussed emphysema, a chronic condition such as emphysema can cause this. So again, everything is overworked, everything is getting tired. The changes within the tissue is going to make things to where it's not working effectively. Oxygen levels are going to get very low, and the carbon dioxide levels are going to get very high. That can affect our pH, and basically everything is going to start shutting down. Okay, it can be a chronic on top, or it can be an acute disorder on top of a chronic disorder. So let's say our emphysema patient developed pneumonia or a pneumothorax, or for some reason their central nervous system has been depressed because, say, we gave them too much pain medication, or they took too much of their antidepressants. Okay, so we already had a problem with the emphysema to begin with, and now we are adding a secondary problem on top of that. Our lungs already have to work really hard to overcome the emphysema to begin with. If we add another problem on top of that, the lungs are definitely going to get overworked, and they're going to want to stop working. Okay. We can have an acute respiratory problem that can cause this. So some sort of chest trauma. So if we have, say, a stab wound that caused a tension pneumothorax, we can go into respiratory failure because of that. PEs can cause this. Again, blood flow has been disrupted through the lungs. It's going to cause everything else to kind of stop working. And so respiratory failure is definitely going to be a thing. Okay. With asthma, if we're talking about the status asthmaticus that can happen, that can definitely send somebody into respiratory failure. If you think about all the muscles that have to work with the respiratory system so that we can actually breathe, basically everybody's getting tired and it just wants to stop working. Okay. Some of our neuromuscular disorders like ACLS, myasthenia gravis, Guillain-Barré, any type of disorders that is going to mess with how our muscles function with the respiratory system can also cause somebody to go into respiratory failure as well. Okay. So we've talked about this before on many occasions, so explain how severe hypoxia, so low oxygen levels and high carbon dioxide levels, are going to affect the central nervous system. Okay. So let's just look at the low oxygen levels. Okay. What does our body survive on? Oxygen. So if we have low oxygen levels, things are going to start shutting down just because they don't have oxygen. So central nervous system is already not going to like the fact that we don't have oxygen. Okay. With high carbon dioxide levels, this is only going to make matters worse. With high carbon dioxide levels, this is going to make things, make our blood pH more acidic. And acidic conditions also shut down our central nervous system as well. So we have low oxygen levels, which are going to shut it down, and we have low pH of our blood, and that is also going to shut everything down. Okay. So if you have a combination of severe hypoxia and hypercapnia, we are definitely going to shut the central nervous system down for good. Okay. So it is always good that if we can correct this. Now, patients who slowly get to this point, like our emphysema and chronic bronchitis patients, your body's going to adjust to it slowly. Okay. This is something that's happening very acutely or suddenly, then our central nervous system does not have time to adjust, and it will basically shut down. Okay. All right. Well, if you have any questions involving any of the material that we kind of covered at the very end here, just either shoot me an email. You can ask me in class. You have me on Remind. Any of those places, you can certainly ask a question. And hopefully this all makes sense. And good luck on your finals.